Hello. Croeso. Good afternoon and welcome to Public Health Network Cymru's COVID-19 webinar series. My name is Bevan Jenkins and I'm a Principal Public Health Practitioner within the Primary Care Division. It's a pleasure to be here today to introduce this session, which for me personally brings together colleagues old and new. In my role within the Primary Care Division, we're leading the coordination of the 4 social prescribing deliverables in the Connected Community Strategy and working with Welsh Government on the development of a social prescribing national framework for Wales. So it's really exciting for me to be here today to listen to all the presentations and share this information with you. Social prescribing is something which has been developing throughout Wales over a number of years and has evolved here very much from grassroots initiatives. The impact of the COVID-19 pandemic and the wide-ranging effects on the health and well-being of the population has created increased focus on these initiatives as one way in which support our recovery. The speakers today are going to discuss the work of their respective organisations, what they're carrying out, which will help to add to the evidence base for social prescribing, support the national development of the social prescribing agenda, and also deliver on-the-ground green social prescribing pilots. A few housekeeping messages to run through quickly before we commence today. So after the presentations, there'll be a chance for you to ask questions. Please use the Q&A box at the top of the panel at the top of the screen to type in your questions throughout the webinar. The webinar is being recorded and will be made available later today on the Public Health Network Cymru's website. English and Welsh subtitles are available. These can be switched on using the bottom right of your screens. However, we are aware that Welsh auto-generated subtitles can sometimes be inaccurate. If you experience any difficulties with the technology today, please let us know through and put in your message in the question and answer box and the team will contact you directly. So the first of our speakers today is Jules Davies, who is Recreation and Wellbeing Convener for the Valleys Regional Park. Julie has over 30 years experience in public health and community development, including roles that have spanned public, private and voluntary sectors. Julie's previously held roles include being a health programme manager within the Community's First programme through to working in a local public health team, latterly focusing on embedding prevention work in primary care clusters. Julie also had the post of Services Project Manager for Macmillan Cancer Care, working extensively with all local health boards across Wales. Her work always has co-production at its heart, and she has particular interest in insight research with communities in relation to initiatives such as social prescribing. Julie will be followed by David, who's Integrated Wellbeing Networks Lead for Aneurin Bevan University Health Board. David Llewellyn began research molecular biologist by training and former profession. He's worked primarily on supporting and enhancing community wellbeing over the last 15 years, with a major interest in connecting communities with their landscapes for mutual benefits. Having led the development of the current Valleys Regional Park with the Welsh Government, he's presently the Integrated Wellbeing Network Lead in the Caerphilly County Borough area. Finally presenting, we have Carolyn Wallace, who's Professor of Community Health and Care Services at the University of South Wales, Associate Director of Prime Centre Wales and Director of the Wales School for Social Prescribing Research. She's a nurse with over 20 years experience in the NHS as both practitioner and manager, working in hospital and community settings, particularly in frailty and integrated care. She's been a trustee at Age Cymru Gwent for over 7 years and is currently its chair of the Board of Trustees. Her experience of working in both health and social care settings have informed her approach to social prescribing research. And for the Q&A session today, we're really grateful to Sally Rees, who is from Wales Council for Voluntary Action and is the National Third Sector Health and Social Care Manager. She's also currently chair of the Wales Social Prescribing Research Network, which they host. Sally's also a member of the Wales School for Social Prescribing Research Steering and Operational Groups. And as I say, she's going to be facilitating the question and answer session today for us after the presentations. We begin the presentations now. I'll hand over to Julie.
Thanks, Beth. Afternoon, everyone. I mean, I'm presuming there's someone there. We never really know when we do these things, do we? So afternoon to anybody who is out there in the ether somewhere. Yeah, my name is Jules. I'm from the Valleys Regional Park, wearing two hats at the moment. I'm currently the acting strategic lead for Valleys Regional Park and the Recreation and Wellbeing convener. I'm going to really race through this bit, which is just a little bit of a background about Valleys Regional Park, and then we can get on to the actual stuff of social prescribing then. So in short, Valleys Regional Park is a European, if we can stay on the other slide for now, if that's okay. So in short, Valleys Regional Park is the European RDP funded landscape-based programme that was initially part of the Valleys Task Force. As for what a Valleys Regional Park is, I've been doing this 18 months and I still can't quite explain what it is. It's a bit tricky. So I'm just going to read a definition which comes from the New South Wales, I believe, New South Wales National Parks Organisation. So regional park is land reserved to protect and conserve areas in natural or modified landscapes. They're suitable for recreation and enjoyment, the likes of which may not be permitted in a designated national park. So I take from that, in other words, you can do stuff in the VRP that you can't do in the Brecon Beacons National Park. That's my interpretation of it anyway. So that's kind of what the Valleys Regional Park is. Next slide, please. Does what it says on the tin, really. Our mission speaks for itself. We seek to bring together the health of the land, the people and the economy in everything we do at the Valleys Regional Park. This has obviously never been more important than now, where it's still seen to be safer outside because of COVID-19, and when there's a declared climate and nature emergency and a really desperate mental health crisis. It was sort of bad enough before COVID, and now we've got some real crisis on our hands there. So the use of outdoor space, because obviously I'm talking about green social prescribing today, as a health prevention and protection resource. It's evidence-based, and it's never been a greater need for it than there is right now. Next slide, please. So we've got a lot of strategic aims that I won't bore you with, but the most key one for today's talk, I think, is that people are reconnected to the Valleys landscape for their well-being. Again, just does what it says on the tin, really. And in this context, we're going to be talking about that from a social prescribing perspective. Next slide, please. The way VRP aims to do this, Valleys Regional Park aims to do this, is through a network of what we call discovery gateways. They are parks and green spaces, and the map there shows the 12 that we've got across the Valleys footprint. So as part of Valleys Regional Park, they were funded to the tune of, I think it was about 7 million in the end by Welsh Government to make them examples of good practice. Basically, they're highly visible green spaces and they're embedded in communities. And just to give you sort of an idea of the amount of people we're talking going through these resources, they currently have, these 12 currently have well in excess of 1 million visitors a year. And to put that in context, for example, in Bringarw Country Park in Bridgend, they have over 200,000 visitors a year, which is more than the population of Bridgend, the town it's based in. So they're obviously a big draw for people. And they act as, we kind of call them launch pads into wider green spaces, and they seek to really inspire and inform and educate and engage people from those communities back into the natural environment, as well as obviously being a bit of a tourist draw too. In fact, VRP was recently quoted by Sophie Howe, you all know, to be the Future Gens Commissioner, as Valleys Regional Park is the National Nature Service in action. That did our Twitter numbers the world of good, I can tell you. So thank you to Sophie for that. So in short, these green spaces provide ideal settings for settings-based approach to green social prescribing. And the next slide, please. In terms of what Valleys Regional Park does with social prescribing, and as I say, this is from the green aspect, we've got a sort of, you know, that old-fashioned two-pronged approach, what we used to call in community development, top-down, bottom-up, strategically, desperately really trying to influence less short-term funding, more core funding, and more cohesive delivery of nature-based prescribing, which lots of organisations are already delivering. Operationally, trying to join those many great organisations that provide on the ground evaluated projects that can be used for health settings as non-medical evidence-based referral pathways. So that's kind of where we are at Valleys Regional Park, and the sort of, the approach that we're taking, both to try and influence strategically and operationally. And the operational bit brings me nicely now on to introducing Dave to you, who's going to talk through one of those pilot projects at the moment, which is the Caerphilly Nature project, Nature Prescribing project. And then I'll pop back to tell you a little bit about how we're evaluating that project. So over to Dave.
Okay, could I have the slide, please? Okay, thanks very much, Jules. Good afternoon, everyone. I'm David Llewellyn. I work for the Aneurin Bevan Health Board Public Health team, and I lead on something called Integrated Wellbeing Networks in the Caerphilly County Borough area. What we're trying to do through Integrated Wellbeing Networks is essentially to sustain and enhance the well-being of people in our communities, keep them as healthy as possible, mentally and physically, and of course that also reduces stresses on the healthcare system. The approach we're using really, I suppose, is an assets-based community development approach, connecting people to all those wellbeing assets, activities and services that support their wellbeing in their communities. Now that can be things like community centres where you have activities including the likes of dance, singing, just people getting together really. But of course, within the context of the Valleys, and Jules has mentioned this with the Valleys Regional Park, we're very lucky in the foremost of those assets are also, of course, including our natural green spaces, so our country parks, urban parks, but also the outdoors, which really are on the doorsteps of people who live in the valleys. So what we are keen to do as part of the IWNs and as a health board is to ensure that people are active or become more active in nature. To do that, they need to know what's available, and in some cases they need help or signposting to those activities. Now, what we saw during COVID, of course, is people during the pandemic and the lockdowns, is people did become more active outdoors in some cases on their own. But we know that for some people, especially those with health issues in some cases, then it's really helpful for them to get referred. And that can be informally through their networks, for example, their social networks. But we felt there was a role for the GP surgeries and other primary care practitioners to be able to do this, which is the basis, I suppose, of our wellbeing prescription here in Caerphilly. So could I have the next slide, please? Thanks very much. So I'm sure some of you will be aware of this, but it's quite clear now from all the evidence that, connecting people with nature and then being active outdoors can really have a huge impact positively on their health and well-being. It can improve mental health, reducing stress and anxiety. We know getting more physically active can also help prevent chronic diseases, particularly things like type 2 diabetes and hypertension, and help with better weight management, for example. And of course, if those activities are done in a communal setting, which they can be, of course, then that can promote and create social connections. And this all has the benefit of supporting and enhancing well-being of people. And I do want to mention that we can have environmental benefits as well, of course. I tend to call it a virtuous circle where people work in the environment or are active in the environment, they look after it, and the environment looks after them. And I think that's really important in terms of people's well-being, not only personally, but in terms of the place they live. So I just want to put you in the sort of footsteps, I suppose, or the shoes really of a GP maybe, or somebody like a psychological well-being practitioner, who I'll mention in a moment. If you were confronted with somebody in your surgery and they may have some mental health issues or physical health issues, and you feel they need something to support that, then often, of course, the easiest route may very well be something pharmacologically, so something like an antidepressant or so on. But we know, and I've given this little example of Zoloft, which is sertraline in this country, or Lustral, and we know that that might benefit people in terms of their mental anxieties or mental health issues, but it doesn't come without side effects. What we do know is that if we can get people active outdoors, they will get a lot of the benefits in terms of addressing their well-being issues and supporting and sustaining their well-being without those side effects and getting all the communal benefits, etc. as well. So we've seen some real progress, I think, over the last few years with the types of activities that are now starting to be prescribed. There was a really interesting paper last year by Anna Jorgensen from the University of Sheffield saying, should GPs be prescribing literally activities in nature to support people's health and well-being? And very, very recently, building on a programme that's been active in Scotland for a couple of years, in Edinburgh now, as it shows on the slide, nature is being prescribed by a small number of GPs to support health and well-being. Could I have the next slide, please? So in essence, we know that people have the opportunity to get out, be active in nature, and as I see it, there are these sort of two complementary strands to support people to do that. An informal signposting strand, if you want to call it that, where we adjust, there's already lots of things happening in a community, community-led activities, third sector providers, for example, doing lots of outdoor activities. And it's just a matter really of helping promote those, signpost people to them, and to raise awareness amongst professionals. That could be GPs, but it can be also other sectors as well. And of course, amongst communities themselves, so that people can say, oh, by the way, do you know this is happening at this park or out in the outdoors there, etc. And what we'd like to do is support and enhance those activities. However, I think complementary to that, there's what I would call a formal prescribing route, which I just touched upon as a course in Edinburgh, for example, with GPs. And that is where somebody maybe come into a surgery, hasn't really got those social connections to be able to feel confident to go out on their own or with others to undertake those activities. And therefore, there's an opportunity for the GPs, the practitioners, to actually refer or prescribe those people there. Now, what we wanted to do was to try to make that as simple and effective as possible for the practitioners, but also the patients. We wanted to get a mechanism that would allow that to happen. And we obviously needed it to work for the people who were providing those activities in the first place. And what we also wanted to do was to evaluate the impact of that then across the whole of the players in this. So the participants obviously are key, but also the practitioners themselves and also the providers. So we can understand how we can move this forward as a proper working model within our health system. Could I have the next slide, please? So this is a little bit about how we've done this pilot in Caerphilly, which we've called Nature Wellbeing or Nature Wellbeing Prescription. And I said in the last slide that this was about being cooperative and not competitive. And I'll explain what I mean by that in a moment. But basically within Caerphilly, we have these neighbourhood care networks, one of which is highlighted in blue there for Caerphilly North. And there are 21 GP surgeries plus some satellite surgeries in Caerphilly. We were lucky to have the support of the neighbourhood care network lead in the East, Lloyd Hambridge, who was very influential in supporting this. And we basically went out to all the GP surgeries to start with and say, are you interested in doing this? And can you tell us why you don't do it now and how you would like to get it to work if you are interested? On the other side of the scale, as it were, we went to the providers as well. And this is what I meant by being cooperative as opposed to competitive. I've worked in the third sector. I know that very often the third sector organisations are in competition with each other, for example, for funding and logistical support, etc. But what we said is, if we could all cooperate in terms of providing activities which are complementary to each other, that gives a much better offer to the GP surgeries in order to be able to refer people to their activities. So actually, by being cooperative and working together, there was enough to go round, and hopefully by changing the model in terms of how we can support you in future as a result of the pilot, then this was going to be to everyone's benefit. So there is a website, as you can see there, naturewellbeing.wales, and the basics and how the model works is essentially on that. And I'll take you through it now in terms of what it's actually meant up to now. So could I have the next slide, please? So this was the model that we came up with working with GPs and the providers. We wanted to make it as simple as possible. The GPs told us very clearly that they have limited time with their patients, and what they really needed have was a very simple system by which they could refer appropriate participants to a program, and that then they would essentially not have to know exactly everything that was available, but nevertheless then they could be assuaged that there was good quality in terms of the activities that people were taking part in. So this is the very, very simple model. Somebody goes to their GP or psychological wellbeing practitioner who sit within the surgeries themselves. If they feel that that person would benefit from taking part in outdoor activities, all they had to do was to email their details to a central coordinator, which we set up for the duration of the pilot. We started this pilot around about the start of July. What the coordinator then does is to work with all those providers to say, what do you have available and where? And this person then is interested in taking part in those activities. So the coordinator has a bit of a discussion with the person who's been referred and said, what would you like to do? Where would you like to do it? And I will now put you in touch with a provider. What the providers do then is provide the activity, surprisingly enough, and what they have done with those participants is a Warwick Edinburgh type assessment at the start of 14.1, plus a sort of physical survey in terms of saying, you know, are you okay to take part in this, and then tailor the activities appropriately. And then the participants take part with the provider, and it's been over a 12-week period. The participants are also given the opportunity to self-assess themselves during the programme, and then at the end of it, and it's coming to an end about now, they will take part in a post-programme assessment, and then those results, if you want to call it that, will go back to the GP. But hopefully what it means for the person involved is that they continue to undertake activities of their own volition outdoors with a number of different providers, and hopefully their visits to their PWP or GP either disappear or are very, very much reduced. So in essence, we've had 40 referrals over a 5-week period, and this pilot, as I said, is still ongoing but coming to the end at the moment. So can I have the next slide, please? So very quickly, before I hand back to Jules, who will tell you about the evaluation, because we work with Valleys Regional Park in terms of the evaluation. What were some of the lessons learned? We really had to sit down with the primary care sector in the first place because we wanted to understand their needs and concerns, and some of these were around, you know, I don't have a lot of time, and particularly during the pandemic where a lot of referrals, etc., or appointments rather, have been done by phone or virtually. The PWPs, these are people who specialise within with mental health, low-grade mental health issues, if you wish to call it that. I think it's a bit unfortunate term, but that's what it's often called. They get more time, so more of our referrals actually came through the PWPs as opposed to the GPs. And what we also knew, or found out rather, was that certain GPs would be far more amenable to this approach or this type of model than others. So we want those to be in the vanguard and real advocates, because I think it's important that that peer-to-peer knowledge is expressed between GPs, and that then will persuade others to come on board. As I mentioned before, in terms of the providers, we wanted them to be cooperating with each other in a co-productive approach. I really do understand the competitive aspects which come forward when you've got to put for funding, for example, to keep yourselves afloat and so on. But what I hope we can do is to ensure that we change the whole model. Nature doesn't come for free. We've got to make sure that these providers are provided for in terms of what they can do with their activities, and that means supporting them financially and logistically. And so what I would like to think is in Wales, we spend about 50% of our annual budget from Welsh Government on health and social care. Just even top slicing a small amount of that could go forward to providing providers with the resource they need to provide these activities to support our patients who are coming forward with mental health or physical health issues that can be addressed in this way. So that's what I mean by transforming that model. And the providers have been brilliant. It also means that by having a number of different providers, then there's a menu really for people to be able to say, well, actually, I'd rather do some nature conservation, or I'd rather walk in nature, or I'd rather do some tree planting, or whatever it happens to be. But it means that we tailor what's available to that particular person's need and where they'd like to do it. And I think the other message that's come through is that we needed the system to be very clear, and that's where the basis of the coordinator, the website explaining exactly what was available, and having the providers put forward a very clear program of activities. I think that helps as well. So our next steps really is what we would hope that we can learn from the model, and we're going to be evaluating that at the moment. And I'll just say a little about that in a moment. But could we do this on a wider Aneurin Bevan footprint? And we'd like to get pharmacists involved, and maybe even job coaches, for example, from the Department of Work and Pensions, for example, who see people very often coming to them with a lot of issues, particularly around their mental health, etc. So I'm just going to hand you back to Jules now in a moment. But just to say about the evaluation, it is ongoing. It will provide the evidence base for us going forward. And we see it very much in a 4P way, as I put it. What does it mean for the participants? What has the model meant for the participants? What the activities have meant? What has it meant for the providers and also the practices? And then how do we progress that? So that's what I mean by that sort of 4th P. How do we now take it forward? And apologies to Jules, because I think I said only 3P when I gave her my first slide. So she probably wouldn't have the progress bit on there, but that's what she's going to tell you about now when it comes to the evaluation part. So thanks very much for listening to me, and I'm happy to take any questions on it as we go forward later on. So over to Jules.
Thanks, Dave. Yeah, I've lost a P between the last slide and this slide. So I'm going to be talking about the 3P approach. So if I can have the next slide, please. Thanks very much. So, you know, for those of you who know a bit about research, none of this will come as any great surprise. We're trying to take a mixed method approach to those 3Ps, the participants, the providers and the practitioners, and we will of course be looking at the processes as well to give us that 4th P back. So mixed method approach, as in we're looking at quantitative, you know, the numbers, and we're looking at qualitative, what did it actually do for people, and that all taps into things like social return on investment and that sort of wider proof, if you like, that these things work. So, you know, none of this will come as a great surprise. We'll be looking at the numbers who've been referred, the numbers that progress onto attendance. There's often with these kinds of things, there's a big attrition rate. We know that from things like smoking cessation and those kinds of traditional sort of complex health interventions, that there's often quite a big attrition rate. Early indications are that there was a really low attrition rate here. We don't know that for certain yet, but I think that was looking as if it was going to be the case, which is great. Things like overall uptake, reach numbers, you know, what's the geographical rate, reach and the condition specific reach. I'm also doing another one at the moment in Carmarthenshire, which is for people with fibromyalgia diagnosis. So we're going to have some evidence of sort of comparing and contrasting in terms of some conditions as well, what the uptake is like and what the reach is like. And then, as Dave said, we'd be looking at that 14-point Warwickshire Edinburgh scale, which is very much accepted now and very much used by third sector organisations, which is brilliant, because lots of you who've heard me speak before will have heard me say, you know, trying to go from smiley face questionnaires to randomised control trials and suit the clinicians that want that sort of information. We've got to do some middle ground, and things like the Warwick Edinburgh are really helping with that. And it's a big hats off to the third sector. In the last 20 years, I've seen them move massively towards evidencing what they're doing in a really robust way. So that was the quantitative side of it. Can I have the next slide, please? Okay, and then looking at the qualitative element, which includes questionnaires and case studies. So looking at how the acceptability, you know, did people like it? What did it, you know, what would they like to have changed about it, etc. Their progress, again, through that Warwickshire scale, willingness to continue past pilot stage. For me, this is absolutely crucial for someone who's had, I don't like to say 30 years in this game, but I have. I've seen so many amazing things come and go and people just drop out of them at the end. So what we really need here is some sustainability, people actually carrying on. And as David said, you know, the virtuous circle, this isn't just about health of people, this is about health of the environment, and we need people to carry on with this work in inverted commas, both for their own health and the health of the environment. And then looking specifically from our perspective at the part nature played in that perceived improvement. So there's a really great body of evidence now around the green element of this, as opposed to just generic social prescribing. And I'm banging on about this being very much being a category in its own right, the green social prescribing. So that's the qualitative element, and we will be doing a sort of 10% of case studies as well to interview people and get a bit more rich data from them in terms of what it's meant to them. Next slide, please. So we'll also then be going to the providers, and there's a list here. You can't see everybody particularly well here, but these are just a snapshot of the great organisations that are already providing this stuff and providing great evidence that it's working. We've got Groundwork, Philly Green Spaces, Active Woods, Gwent Wildlife Trust, as down the bottom there, Valleys Regional Park. So some great providers there that have been doing this despite not having regular funding, or funding that goes on longer than about 3 years. So we're asking them things like, how did they find the referral process? We've got a sort of voluntary coordinator at the moment that's referring people, but we know that there's going to be necessity for there to be a post that does that. How long are they funded for, and who are they funded by? That's just for us to get that. You know, we know anecdotally people are funded short term and they spend a lot of their time looking for funding to keep themselves going. Were the numbers manageable? As Dave said, at the moment, I think we're up to about 40. Was that manageable for providers? 2, 3, 6 each? How many could they actually provide places for? How many could they accommodate? And would they like to continue their involvement in this? It's not beyond the realms of possibility that it might have been tricky for them. So, and also, would they be willing to be part of a case study? So that is the sort of thing we're asking in terms of the providers. Next slide, please. And then on to the participants. We've got the Warwick Edinburgh there, as we've mentioned a few times. So that's a nice, you know, validated scale that people are using. So we can use that to measure, you know, if people have improved from the time they started to the time they finished. And then we're also developing a questionnaire just to ask participants, how did they find the referral process? We know a lot of people really struggle to just go to these things on their own. If it was that simple, everybody would just be going. So people really need some sort of, you know, whether it's local area coordinators or the psychological wellbeing practitioners to support them through the referral process. So we're going to ask people how they found it. Are they going to stay involved in the great outdoors in some way? And would they like advice on what else is available? And that'll give us an indication about whether people just did it for short term because they were told to go and do it, or whether they're going to carry on afterwards. So that's the sort of thing we'll be asking the participants. And the next slide, please. Coming on to the practitioners, and that's the GPs, the social prescribers, the psychological wellbeing practitioners, and every other name that they're known by. So asking questions like, how aware were they before the pilot of this? How aware were you before the pilot of the mental and physical health, of the wellbeing benefits of nature? I think most people are aware it helps, but how aware are these people that have been referring people of the benefits of nature? How did they find the referral process? We got some triangulation going on there to find out how everybody concerned found this referral process. Do you feel this type of project would help reduce pressure on GP appointment time, medication, etc.? Let's not put too fine a point on this. That is really important, obviously, from the point of view of, you know, strapped services and GP's time and prescription charges, all that kind of thing. It has to alleviate some of that pressure for people to want to refer people through. Would they be willing to be part of case studies? It would be really interesting to find out in more detail what makes this sort of thing difficult for primary care referrers, because we know not everyone is as on board as we'd like them to be. So it would be really useful to find out what are the barriers for them, and would they like to be continue to be involved, which again is really important to us to see whether they've been through this process and it was not so onerous that they don't want to be part of it again. So that's the kind of thing that we will be asking the practitioners, the GPs, etc. And the next slide, please. So what will we use the evidence for? I mean, there are lots of different things really, but we need to show what's being provided. And I unapologetically put this in because I'm such an advocate for, the third sector. They're providing it on a shoestring and it's not sustainable unless somebody very high up starts pouring some money into this. And we know from evidence that, I think the figure quoted was half of what's spent on things like antidepressants doesn't work. So if they could just give us that half, please, the half that doesn't work, that would be very gratefully received. We need to understand the level of demand and buy-in for nature prescribing. We're all talking about it again as, professionals in inverted commas. What is the demand for this really? And, we know that we need to increase the demand from the ground level as well. Joe Public needs to know what social prescribing is, because it doesn't really do what it says on the tin. So what does it mean for people? They need to know, and they need to be able to go to their GPs or their Department of Work and Pensions or job centres or their social landlords, tenants associations and say, I've heard I could go and do X, Y and Z. How do I get to do that? So, we need that. If it was a business, we would need that demand to be led from people, real people. So we need to gauge that level of demand. And is there a demand for primary care? Do they really want to refer across to these things? Then the benefits to GPs, practitioners, patients, we need to be able to capture those in one place, Caerphilly specific in the first instance. But my job then will be to look at how we promote this across, in my particular field, in the valleys areas. That's something that could be replicated in other areas with tweaks to suit the local areas, obviously. And then to illustrate again, as if we need to illustrate this even more, the need for core funding to support the social prescribing agenda, but from my point of view, the Green Social Prescribing agenda. We really need communities to know that this is available, and we really need people to start demanding it, and we really need some more money put into it so that these providers can keep going. So that's what we're going to use this evidence for. As David said, really happy to answer questions at any time and circulate these results really widely to people when we've got them. So that's sort of the on the ground stuff that's happening, the evidence that's being collated. And now I'm going to pass you over to Professor Carolyn Wallace. And Carolyn's going to talk really from the perspective of what's going on in the Wales School for Social Prescribing. And we're really lucky to have one of those in Wales. We're a little country and we do lead the way in this stuff. So I'm very proud of us for that sort of thing. So Carolyn's going to give us an overview of the work of the Wales School for Social Prescribing and, talk a little bit about how the ministerial task force and the work with Public Health Wales, etc. is happening. So I'll hand you over to Carolyn.
Thank you, and it's really great to be here this afternoon. And please excuse me, I have a little bit of a cold, so if I struggle a little bit, hope you'll bear with me. Wales School for Social Prescribing Research, ysgol ymchwil rhagnodi cymdeithasol Cymru, and what a great place it's been to working in this last year or so. You've seen by all of those slides that social prescribing is a really important model for us to help empower people, basically, to improve their own well-being. There are a lot of people out there doing a lot of good things in order to develop this infrastructure. It's not been without its challenges, and social prescribing has faced quite a few with regards to its evidence base. This is because of the nature of it, as you can see by what David and Julia said. It is a model that moves across sectors. It is next slide, please. It is a model which aims to connect citizens to community support to better manage their health and well-being, and that's a definition we're using at the Wales School for Social Prescribing Research. It focuses on what matters to the individual. It co-produces a solution-focused action plan, and it connects them to those community assets. And what wonderful opportunities that we've seen already today. In Wales, we've got multiple models of referral. David spoke about the model that's been developed there with primary care. It's not the most dominant model. We know that through the work that we've been doing with Public Health Wales and the Ministerial Task and Finish Group around developing and understanding the landscape of social prescribing across Wales. We know that it's primarily based in the third sector and the local authorities, but also, as we mentioned already, in primary care, but in housing and other areas as well. You'll oh, next slide, please. And so why do we need the Wales School for Social Prescribing Research? Well, you know, we've already seen that evaluation is really important, and that's one of the important features of the school. And I'll go on to talk about that a little bit more. But Whisper itself was launched in April last year. Not the best time to launch a school, I might add, not in the middle of or the beginning of a pandemic. But it gave us an opportunity to be able to try and tackle those issues that social prescribing have been facing with regards to its evidence base. Please visit the website for a more detailed account of the many studies that I'm going to just briefly mention in these slides in the next few minutes. You'll be able to see what we've done, what we're doing now, and what we plan for the future. Next slide, please. It's a virtual school with members from across Wales who have an interest in research. And when I say that, I mean that everybody has something to offer. Whether you're a practitioner and you've identified a hard to solve problem, we're interested in it. And many of you will have heard me say this before. Whether or not you then, you know, leave that idea with us, or you want to travel with us along the journey, or you're a person who has a lot of experience in research and actively engage and develop, design, and deliver the research yourselves. We're interested in how we can work together. And we were very fortunate to have some funding from Health and Care Research Wales to help us launch this work in Whisper, and we have that until 2023. So our aim is to build the critical evidence base for social prescribing, but not only for Wales and internationally. And we do that through engaging with partners across the world, with our international boards, but also with the partners that come to want to work with us, for example, in Portugal and in other areas of Europe. Next slide, please. So I've got a very busy slide there for you, but what I need to tell you is that the school is based within something called Prime Centre Wales, which is the Primary Emergency Care Research Centre, which again is Welsh Government funded. And we're based within with a theme called Seamless Care Closer to Home, and within the work package Care Closer to Communities. And we have a network, as I mentioned, of researchers, and we have over 350 members, I might add, and we have a steering group, International Advisory Board I've mentioned. We're linked to 3 communities of practice and also to Connect Wales, and we engage with all the practitioners through those forums. We also engage with RCE Cymru, which is a regional centre of excellence, part of the UN universities across the world, and we are their social prescribing circle of interest. Next slide, please. Now, we have 4 themes. we have evaluation, social value, workforce and education, and well-being. Now, we've been developing the evaluation methodology framework for social prescribing. It's called the Accord Study, and within that we've got evaluating reporting standards. And you'll be asking the question, why on earth are we doing that? Well, because what we've got a problem. We've got a problem that evaluation across Wales and across the UK and across the world, well, we happen to be trying to compare apples with pears. So what normally happens when you're doing that is that you can't really compare and you can't really build the evidence. So with reporting standards, that will be shared with everybody. We'll be able to start to say, well, do you know what? Something that you saw just previously, that mixed methods approach, is really important for social prescribing. And so that's what people should be doing. That's what we recommend people should be doing. And we're putting that within the reporting standards. And you say, well, why should we be doing that? Well, because what's been happening is that people have been reporting their qualitative and their qualitative results separately. That gives you a different answer when you report them together. And what we need to do is report them together. So that's just one example of what we'll be including within the reporting standards. We've also been doing work with Mind and the British Red Cross within projects called Spring and Prospect. We've been also doing some work around enhancing student wellbeing through social prescribing. Yes, social prescribing in universities, been influencing student services. And we've been doing some work around realist evaluation of the Grow Well project in the centre of Cardiff to help us understand a little bit more about evaluation. Next slide, please. Social value, well, that's led by Bangor University and Mary Lynch. Her work around respect, the Gwynedd Breast Project, I Can Work, social return on investment of Active Woods Wales are just a few of the examples that we've got there. And Mary's been developing that programme of work over a number of years. Next slide, please. The workforce and education theme. We're developing training materials. We've been looking at social prescribing learning needs, and I use that term social prescribing in its broader sense, including all of those terms that you've heard today, including link worker, community connector, and so forth. We've also been doing some work around quality indicators for social prescribing. And we're taking that work forward to look at quality standards, and we're doing some work with NICE in that area, and we'll be reporting on that for the Ministerial Task and Finish group. Next slide, please. Wellbeing. Well, we've heard about WemWebs, and it's a great tool, isn't it? But unfortunately, what's come to light is that that's just one part of the story. That's about social and emotional well-being. Well, well-being is also about social well-being. And there isn't a tool out there to measure social well-being. So that's a piece of work that we're doing at the moment. We've been developing the concept of social well-being in the context of social prescribing. And we've developed this tool, and we're in the process of testing it. Next slide, please. Research students. No school would be without their research students, and we have far more than this now, and they're working in all those parts of our work programme. And as of next week, we'll also have a new student who will be working on developing a Once for Wales training programme, education and training programme for social prescribing. So we'll be working with colleagues from the WCVA, from also HEIW, from all sectors in order to develop that piece of work. Next slide, please. The ministerial task and finish group. All of that work, or most of it, will be fed into these core deliverables that the minister is tasked as a group to do. Not just myself and Sally Rees, but also others from HEIW, Public Health Wales. All sorts of people are involved in delivering these four key pieces of work. We as a school have been involved in the mapping, the landscape around social prescribing activity, and many of you who are listening today will have been part of that piece of work, either delivering on the survey, or being part of the focus groups, or you're planning to come to the workshop that we have next week on the 21st. We're helping HEIW with the development of this National Skills and Competency Framework. We have some information, as you can probably gather, to be able to feed into that. And we've been working on the early ideas around developing and launching an online resource portal for social prescribing for Wales. And of course, we're continuing to develop the evidence base and the outcomes framework and the quality standards, which I mentioned before. Next slide, please. Finally, if you want to learn any more about us, then please, of course, drop us an email. But you can also find our annual report, our very first annual report, on the website, and or you can, or if you email us, and you'll find out what we've been doing over this last year. Now, thank you very much. Diolch yn fawr pawb am wrando, and I'll hand you over to Sally.
Good afternoon, everybody. I know that there's been a series of questions posed, but we've only got a few minutes. We're due to finish at 3, and I need to hand back to Bevan. So I'm going to go in no particular order, but I'm focusing on one that's had the most thumbs up, which is 4. And I think this is a question for David, particularly as it's in relation to sort of nature. David, do we need to consider social prescribing outside clinical settings? Many individuals do not have regular engagement with primary care professionals, maybe because of morbidity hasn't established yet, but also the barriers for individuals accessing primary care appointments. Should social prescribing be part of a wider system to encourage being active? So in your case, in particular in green and blue spaces, as being, you know, as a preventative measure.
Okay, the first thing I should say, I hope I haven't sort of misled anybody into thinking that, you know, we see this as the only route. Of course, this is just but one part of the jigsaw, I think, as Carolyn referred to there. Very much so, what we would hope is that, in fact, people will engage with nature, be active in nature and outdoors, doing the things that they love to support their health and well-being, just as part of their everyday lifestyle. That's really what we want at the end of the day. It would be really lovely to think that, in fact, we didn't need any clinical intervention, if you want to call it that, for people to take part in nature. So yes, all those things that where people do it of their own volition, or where they have their, you know, their friends, their family, their community saying to them, well, you know, why don't you get involved in this? So those types of social prescribing networks, informally, if you want to call it that. That's very, very much what it should be about ultimately. But there are going to be a small group of people for whom they may not have that motivation, or they may not have those networks available to them that support them to become active. And therefore, what happens to them, unfortunately, is that they may present at their GP surgery or in front of their psychological well-being practitioner or whatever it happens to be. And therefore, that's why we wanted to make that route available to those people as well. So it's not either or, it's very much that this is part of the overall jigsaw, part of the overall picture, and it provides a route where people who've not doing it normally, part of their lifestyle, can in fact be supported and encouraged to be active in nature to support their health and well-being through a more clinical route in this case.
Thanks, David. I'm going to move on to the next question, and I think this is a question for for Carolyn, although the focus is on local nature, but I think this is relevant in terms of other activities and support that people may wish or want to connect with. What do we know are the barriers and the enablers of being active? Maybe that we could develop interventions for Joe Blogs in commas to shift the pressures from GPs to social prescribing. So Carolyn, over to you for this particular question, because I think it's not just about local access to local nature, but other activities and support.
Yes, thanks very much, Sally. I think the barriers and enablers of being active are many, depending on your circumstances. And of course, there are other modes of social prescribing, such as the arts, craft, and you know, most recently I've been involved with something called the Body Hotel, which is about dance. So there are all sorts of opportunities, not just green social prescribing for people to consider. Now, there are a number of barriers that people face when they are in a situation whereby they are using some form of activity to help them through that situation themselves. And that, you know, for example, some people may find that they can't do it by themselves initially. They can't.
Hi Sally, this is Casper. Hi, I think we've just lost Carolyn for a bit there, and you're also, Sally, your microphone is muted, so we can't hear you.
Ah, sorry about that.
It's okay.
Just to say, I know I've answered some of the questions already in the chat because of time. I think one of the areas that's cropped up, and I have responded is around what's happening in education, particularly further and higher education. And I have posted that if people can contact me and I can link them with Carolyn and with those two particular universities that are involved with the research. One of the questions is about the age and gender demographic of social prescribing referral and uptake. And I don't know whether from a sort of nature perspective, Julie, if is anything you can sort of contribute there in terms of the age and demographic information from the work that you've been doing?
Hi, Sally. No, nothing to contribute at this stage, actually, because we haven't done any research around that. I'm sure there is probably some academic research around age and gender profiles, but no, we haven't done anything on that score. Anything we've done in terms of surveying people in the Valleys communities has just been generic. You know, what would you like to see more of? What have you accessed during lockdown? That kind of thing. So I'm afraid we're not much use on that score. Sorry.
And while you're still there, Julie, one of the questions is around what types of activities have been included in your sort of nature wellbeing, your model. So what types of activities are actually people engaging with?
So I think if we look at just looking at the sort of the list of people who've been involved in the Caerphilly ones and the sort of thing we're doing in the regional parks through groundwork, it's everything from sort of bushcraft to gentle walks in nature, just to get people involved. I know we had one set of walks which were accidentally on purpose at the same time as the conservation group was working in that park, just to walk people past it and show people the type of thing they could maybe get involved in with a friends of group or something like that. So it's really everything from just sitting around a campfire having a chat. We know that brings out a lot of stuff for people if they just sit active, you know, in the woods having a chat. There are people offering Pilates in the woods, walking football in the woods. There's a really big range of things right across that I'm aware of, and I know there's much more that I'm not aware of. So there is something for everyone. I think that's what David was alluding to, really, is, you know, there needs to be a suite of things that when someone goes to the GP, they're not just offered pottery or fishing or going for a luncheon club or something, they are offered a really wide range of things that speak to them. And with the Green Social Prescribing, for all sorts of ages, abilities, demographics. So there's a lot already going on out there, and hopefully if the funding comes through for a lot of these organisations, they will be able to do even more. So massive range of things.
Thank you, Beth. And I know we're just on the 3 o'clock and we're due to end. There are several questions in the chat that we've not been able to get around to, so hopefully we'll be able to answer some of those questions after this session and post them on the network website, so you'll be able to see those. So I'm going to pass you, and thank you very much for all the questions that have been posed. So I'm going to pass you back to Bevan, who's going to close the webinar session today. Thank you, Bevan.
Just to wrap up really and say thanks to all the presenters today, and also to the people who are helping us behind the scenes and sorting us out with all the technology to do this. We're really grateful to everyone for joining the webinar today, and would ask if you can complete a short evaluation. I think the link has been posted in the chat, and I understand it will also be sent out to you later. I hope we also think about maybe joining the Public Health Network Cymru if you're not already a member. Finally, if you've any thoughts on future webinar topics, please let us know at publichealth.network@wales.nhs.uk. And that's it today. Diolch. Thank you.